Okay, good afternoon, everyone. Can you all hear me?
Yeah.
Good. So I'm afraid now we're going to move on to the slightly heavier part of the program, more information-laden part of the program. So when I was preparing this talk, I wasn't entirely sure exactly who was going to be in the audience. And a lot of it may not be completely suited to the audience we have today. Can I just ask if you can raise your hands if you're from a medical background? So we do have a few. And from a nursing background? Great, okay, fine. So I'm sure there will be parts which we can skip over fairly quickly. So as Kofi said, I'm going to talk about iron overload, but at the beginning I'm also going to talk about thalassemias, which will lead on to the part of iron overload. And thalassemias in general tend to be the slightly less prominent disease, even amongst clinicians who are specialized in haemoglobinopathies and healthcare professionals that are specialized in haemoglobinopathies. But it's important that we all know and have a good understanding of thalassemia, the impact it has on patients, and the worldwide impact, really, because we'll go on to see that although in the UK, there may not be as many patients with thalassemias as there are with sickle cell disease, worldwide, thalassemias are probably more common and the most common genetic disorder. Does anyone of interest know roughly how many thalassemia patients there are in the UK? And when I'm talking about thalassemia, I'm talking about clinically significant thalassemic disorders.
1,000?
Yeah, so transfusion-dependent thalassemias, there are probably about 1,000. And then altogether, clinically significant thalassemias, about 2,500 to 3,000. Yeah, and that compares with 15 to 20,000 patients with sickle cell disease. So what are thalassemias? So thalassemia is a term given to conditions where there is reduced production of either the alpha or the globin protein making up the hemoglobin molecule. And the term alpha or beta thalassemia refers to which of the globin proteins is not being produced in normal quantities. So alpha thalassemia refers to insufficient alpha globin production, beta thalassemia, insufficient beta globin production. And that contrasts to the other hemoglobin disorders like sickle cell disease, where there's an abnormal form of hemoglobin that's produced rather than insufficient quantities of globin produced. So this is just a recap, which I'm sure that you'll all be familiar with. This is a diagram of the hemoglobin molecule, which you can see is made up of two alpha and two beta globin chains, and the heme molecules, which forms the center of each of the 4 globin chains. And the heme molecule contains the iron atom. So I've already mentioned the difference between the alpha and the beta thalassemias, which are based on the deficiency in production of either alpha or beta chains. And this is just a diagram showing where the genes are located for the alpha and the globin production. So the alpha globin genes are located on chromosome 16, and we normally have 4 alpha globin genes, 2 on each chromosome 16. So a mutation or a deletion in either of these genes or in the promoter region, or this is called a control or promoter region, which controls the downstream activation of these alpha genes, can lead to a thalassemic disorder. With beta thalassemias, it's a little bit more simple because we only have 2 beta globin genes, which are located on the chromosome 11, 1 on each chromosome, and a mutation in either the beta globin gene or a deletion or in the locus control region here can lead to a thalassemic disorder. Okay, and you can also see that as well as the alpha and the beta globin genes, there are other genes located within the clusters that are responsible for other hemoglobins which are produced during fetal development, as we'll talk about shortly. So this is a slide which I quite like to show, and it shows the different hemoglobins which are produced at various stages of fetal development, well, embryonic and fetal development, and after birth. And you can see here that, with respect to the alpha globin proteins, you can see that they're produced very early during embryonic development. With the beta globin chains, you can see that they're produced later on, because during fetal development and until about 6 months of birth, the main hemoglobin is fetal hemoglobin, which is composed of gamma chains rather than beta chains. Okay? And you may ask why I'm spending quite a bit of time on this slide, but it is relevant because the alpha thalassemias, the severe forms of the alpha thalassemias, present during embryogenesis. Okay? Because as you can see, if you can't produce alpha chains, then you'll be affected very early on during embryonic development. Whereas individuals that are unable to produce beta globin chains, they only manifest much later on after birth, usually about 6 months of age. Okay? And that's why severe forms of alpha thalassemia are usually incompatible with life at a very early stage of embryonic and fetal development, and the developing fetus normally dies in utero with severe forms of alpha thalassemia, whereas with the beta thalassemias, they're normally picked up after birth. Okay, and this is just showing the normal hemoglobins which are present in normal individuals without thalassemic disorder. Sorry that these haven't come out properly, but so as you can see, the vast majority of our hemoglobin is hemoglobin A, composed of alpha 2 and beta 2, so 2 alpha globin chains and 2 beta globin chains. We have a small amount of hemoglobin A2, which is composed of alpha 2 and delta 2 chains, 2 alpha and 2 delta. And normally, we only have a very small amount of residual fetal hemoglobin remaining, which is composed of 2 alpha and 2 gamma globin chains. And this is a laboratory test to see the different types of hemoglobins which are present. And this plot allows us to see the different, or the various hemoglobins which are present, separated out on the basis of their molecular weight and charge. And the different peaks correspond to different hemoglobins. And the largest peak here you can see corresponds to hemoglobin A, adult hemoglobin. This peak here corresponds to hemoglobin A2. And within these peaks here is hemoglobin F, or alpha 2 gamma 2. So that's the normal situation in terms of the hemoglobins which are present. So we've already talked about thalassemia as being characterized by defect of globin chain synthesis, and it is the most common genetic disorder worldwide, single gene disorder worldwide. Does anyone know, out of interest, what does the actual word thalassemia mean? What's the origins of the word thalassemia? You'll have to shout because I can't hear you. Yeah, very good. So any classical scholars will know, or anyone from Greece may know as well. So the words thalassemia come from the Greek thalassa, which means sea, and haemia, or hemia, which is related to the blood. Okay, so the word is referring to a disorder which was first identified around the sea. And when we're talking about the sea, we're referring to the Mediterranean Sea. Okay, so that's where it was first identified and characterized. But as you can see from this map here, the prevalence of thalassemia worldwide is far greater than just around the Mediterranean area. And this is the prevalence of the beta thalassemia gene, or the mutation, in Europe. And I'm not going to spend long on this, but you can see that around the Mediterranean countries, Italy and Greece, there's a very large prevalence of carriers for beta thalassemia. So clinically, we can divide thalassemia into 3 different categories. There's a carrier status, which is sometimes called thalassemia minor or thalassemia trait. Then there's the major form of thalassemia, which is incompatible with life without regular blood transfusions, which we tend now to refer to as transfusion-dependent thalassemia rather than thalassemia major. And then there's a group of disorders in between, which we used to call thalassemia intermedia. Now we tend to call them non-transfusion thalassemia, non-transfusion-dependent thalassemia, which is a heterogeneous group of disorders made up of individuals who may not require transfusions at all, or who may require transfusions intermittently. But these are more severe than individuals who have thalassemia trait. So this is a pedigree, a typical pedigree of a family with beta thalassemia, just to kind of understand the inheritance pattern and where those individuals who have thalassemia major may be coming from. Okay, so maybe it's easiest to start at this point here, because here we can see 2 individuals who are carriers for thalassemia. Yeah, so the beta on its own denotes an individual, denotes a normal beta globin gene, and the beta 0 denotes a beta globin mutation, one of the more severe beta globin mutations. So these individuals here both have beta thalassemia trait. Okay? And because beta thalassemia is inherited in an autosomal recessive manner, what would be the chance of the offspring of these 2 individuals having a severe form of beta thalassemia? 25%, or 1 in 4. And we can see that here. Yeah? So we can see on the probability that 1 in 4 of these individuals, which are offspring from these 2 individuals with thalassemia trait, one of them, 1 in 4, will have beta thalassemia major. 1 in 4 statistically will be normal, i.e. will have no beta thalassemia mutations, and 1 in 2, or 50%, will be carriers and have thalassemia trait. Okay. And this is just showing here that there are other types of mutations as well. There's a beta 0, which is a more severe form of beta thalassemia mutation, and there's a beta plus mutation, which is a slightly milder type of mutation. And it's because of the different types of mutations, the more severe and the milder, that we see, or that's one of the reasons why we see individuals that can have beta thalassemia intermedia. Because if this individual had 2 beta 0 mutations, they would have thalassemia, transfusion-dependent thalassemia or thalassemia major. But because they've inherited 1 beta plus and 1 beta 0 mutation, then this individual has a slightly milder form of thalassemia, which is thalassemia intermedia or non-transfusion-dependent thalassemia. So I'm now going to just talk a little bit about the tests that we use to diagnose thalassemias. And this is a slide which really combines the tests that we use for both beta and alpha thalassemia, although we'll go into each one in more detail. So the full blood count is the first test that we use, and we'll talk about some of the abnormalities that we see on the full blood count, which help us to diagnose individuals with thalassemia. Reticulocytes, looking at the blood film, can be very important in distinguishing between the different forms of thalassemia and the severities. In the case of alpha thalassemia, We sometimes do a test called a hemoglobin H preparation, which if we have time, we'll have a look at. And then one of the very important tests that we do, particularly to diagnose beta thalassemia disorders, is the hemoglobin separation, or HPLC, which is a graph that I showed you earlier for a normal individual. But we'll see a plot for patients with thalassemic disorders as well. And then we sometimes need to go on to do genetic analysis when it's not entirely clear what type of mutation the individual has. Generally, for beta thalassemia, it's not always necessary to do genetic analysis because we can make the diagnosis without it. But in the case of alpha thalassemia, if the patient is presumed to have a clinically significant disorder, then genetic testing is needed to confirm or to clarify the status of that patient. So I mentioned that for beta thalassemia, the diagnosis is more straightforward without the need for genetic analysis, and that is because beta thalassemia can be diagnosed with hemoglobin electrophoresis or hemoglobin separation on the basis of a raised hemoglobin A2 percentage. Okay, and here you can see the normal range and the range that we see in patients or individuals with thalassemia. Okay, so with beta thalassemia trait, or the carrier status of thalassemia, the individuals are usually asymptomatic. However, they can become anemic during pregnancy or if they were to develop an infection, an intercurrent infection. However, the main significance is genetic because they can pass on the mutation to their offspring, and there may be interactions between two parents who have interacting disorders. Two parents with beta thalassemia trait, as we've discussed already, have a 25% chance of having a child with beta thalassemia major. So we said that we're going to talk about the abnormalities in the various diagnostic tests in a bit more detail. And here are the salient features on the full blood count, which would point to a diagnosis of a thalassemic disorder. So we can see a reduced MCV and reduced MCH, what we refer to as microcytic hyperchromic red cell indices, and a raised red cell count. And this individual has a normal hemoglobin. This is a male patient. Normal hemoglobin, which is not unexpected in a patient with beta thalassemia trait. Okay, so these indices would be consistent with a patient with a thalassemic carrier state or thalassemia trait. So these are some HPLC plots from a normal individual, which is the same as the one that we saw earlier. And this is, on the right side, a plot from an individual with beta thalassemia trait. And you can see here the main difference. Again, we can see the main peak here is hemoglobin A, which is present in both individuals. But the main differences are the level of the hemoglobin A2. You can see here, this is a normal level, and this is a raised peak, showing a raised hemoglobin A2 percentage in the individual with thalassemia trait. And there is also a raised hemoglobin F compared to the normal individual, which is also commonly seen in patients with thalassemic disorders, so raised hemoglobin F levels. So it's important to also be aware that as well as two individuals with beta thalassemia trait, giving rise to the possibility of an offspring with a significant disorder, i.e. transfusion-dependent thalassemia, beta thalassemia can also interact with other hemoglobin variants. So beta thalassemia can interact with hemoglobin S, producing a sickling disorder. So hemoglobin S beta thalassemia, which is a sickling disorder. And it can also interact with hemoglobin E to produce a a form of thalassemia, usually a non-transfusion dependent or thalassemia intermediate picture, but occasionally more severe. So hemoglobin E co-inherited with beta thalassemia. In terms of thalassemia major, so the transfusion-dependent form of thalassemia, these are normally fairly straightforward to diagnose, although it's important to be aware that it may not be apparent immediately after birth that the individual has a severe form of thalassemia, and that's due to the high levels of fetal hemoglobin which persist for a few months after birth. But these individuals will, after a few months of birth, become progressively anemic, and as I've said here, usually presents between 3 to 6 months of age. And these are some of the clinical features which may be present: hepatosplenomegaly. The blood film will normally show very striking and gross abnormalities, including the presence of nucleated red cells. And many of the features, clinico-pathological features, are due to a combination of hemolysis and extramedullary hematopoiesis. These patients also have many other clinical features, including chronic fatigue, failure to thrive, jaundice, delayed growth in puberty, skeletal deformities, splenomegaly, and iron overload. They may also develop gallstone disease due to the chronic hemolysis, and biliary sepsis, cardiac failure, which can be a consequence of chronic anemia, but also iron overload, endocrinopathies, and liver failure. Okay, so we're just going to have a look at a few pictures now of some clinical manifestations of thalassemia. So in the past, where patients were not well transfused with thalassemia, it was not uncommon to see the clinical manifestations with the expansion of the frontal bones and other bones in the body due to the extramedullary hematopoiesis. Okay, and in many parts of the world, we still see that patients are not well transfused, and we're still seeing these kind of clinical features. This is described as the hair on end appearance, which can be seen on radiographs in various parts of the body, but particularly here in the skull, described as the hair on end appearance. And again, this is due to erythroid hyperplasia within the skull bone. Here we can see very marked expansion of the medulla within the metacarpal bones of the hand here, again due to the extramedullary hematopoiesis. And here you can see some kind of background explanation to why these kind of pictures are still seen. Transfused, this child, 7-year-old child, was transfused only occasionally due to economic constraints. Here we can see gross expansion of the ribs, again due to the intramedullary hematopoiesis. And here we can see this extramedullary hematopoiesis of the paraspinal area. So this is essentially a paraspinal mass due to extramedullary hematopoiesis in a poorly transfused patient with a severe form of thalassemia. And this, in this particular patient, led to spinal cord compression and paraplegia. And here we can see a very gross example of compression of the brain due to extramedullary hematopoiesis around the cranium. So moving on to the management of thalassemia. We're talking here about the transfusion-dependent, the more severe forms of thalassemia now when we're talking about the management. As I mentioned earlier, patients with thalassemia trait have a mild picture which does not normally need any clinical intervention. So management of the more severe forms of thalassemia include transfusion therapy, management of iron overload, possible splenectomy if indicated, supportive medical care, endocrine involvement from the endocrine team, which may involve hormone replacement therapy. Hydroxycarbamide may be used in some patients. And then we'll talk about some of the newer treatments, curative and newer treatments. It's important also to be aware that patients with thalassemia are at risk of infections. We normally think of sickle cell patients of being at higher risk of infections, particularly with the encapsulated organisms due to loss of splenic function. Thalassemia patients are at risk of certain infections as well, including Yersinia, which is a siderophilic or iron-loving bacteria or bacterial organism. Due to the iron overload, they have a higher risk of this organism, as well as other gram-negative sepsis. And in patients who have been splenectomized, they will also be at risk of the same encapsulated organisms that we encounter in patients with sickle cell disease. We've talked about these already. So in terms of transfusion support, these patients will require regular lifelong transfusions. And where possible, we aim to give phenotyped red cells to minimize the risk of patients producing red cell antibodies or alloimmunization. And in order to reduce the risk of extramedullary hematopoiesis, we aim for a pre-transfusion hemoglobin level of between 95 and 100 grams per liter. This normally requires 2 to 4 weekly transfusions, and if patients have a higher requirement than that, then splenectomy would be a consideration. Just a slide on hemoglobin E beta thalassemia. I mentioned earlier that a clinical interaction between beta thalassemia and hemoglobin E can lead to either a transfusion-dependent or more commonly a thalassemia intermediate non-transfusion dependent type of thalassemia. So hemoglobin E is very common and prevalent in Southeast Asia. Okay, so in these individuals from these parts of the world, it's important to consider that possible interaction. In terms of alpha thalassemia, the diagnosis, as I mentioned, is a little bit more difficult because of the lack of a diagnostic laboratory test and the need for genotyping, alpha globin genotyping to confirm the diagnosis. These conditions are related to deletions or mutations in one or more alpha globin gene. Okay, and as we mentioned earlier, this affects both the developing fetus and the individual later on in life. And in alpha thalassemias, we see precipitation of beta globin proteins and gamma proteins forming tetramers of HBH and HB Barts. And these can be detected in increased quantities in patients with the more severe form of alpha thalassemia, which is a 3-gene deletion. So yeah, the severity depends on the number of alpha globin genes deleted. And this is just a really quick run through to show you that normally we have 4 alpha globin genes, and there's quite a number of different permutations in terms of loss of alpha globin genes. So this is a single alpha loss, usually due to a deletion, which is usually asymptomatic. In fact, I would say it would be always asymptomatic. Here we have loss of 2 alpha globin genes, but you can see here that there are 2 possibilities. Either we have 2 alpha-globin genes lost on the same chromosome, or 1 on each chromosome. And this is clinically significant in terms of inheritance, because an individual passing this on to their offspring would be more clinically significant than an individual passing on a single alpha-globin deletion to their offspring. And then we have 3 alpha-globin deletions here, which is basically a combination of this chromosome and this chromosome, and this is referred to as hemoglobin H disease. And then we have loss of all 4 alpha-globin genes, which is incompatible with life and almost always results in utero death. And this is just showing that the alpha deletions, the alpha plus deletions, and the alpha 0 deletions are much larger deletions spanning across both of the genes on the same chromosome. I did mention earlier about the hemoglobin H prep, so this is an example of that. So this is a supravital stain applied to the patient's peripheral blood film. And these cells here, which are commonly referred to as golf ball cells, you can probably see why, they are showing precipitations of beta globin chains. Yeah, so these are characteristic in patients with hemoglobin H disease. You can also see a few of these types of cells in patients with 2 alpha deletions, so alpha 0 thalassemia trait, but more commonly, particularly when we're seeing this large number of these golf ball cells, this will be in patients with hemoglobin H disease. And here, the HPLC plot in a patient with hemoglobin H disease, you can see here these 2 peaks right on the left side of the plot. These fast diluting peaks are hemoglobin BARTs and hemoglobin H, composed of gamma and beta tetramers. Okay, so when we put it all together in terms of making a diagnosis and assessing the patient with thalassemia, we need to look at the full blood count, red cell indices most importantly, and then if we're suspecting a thalassemic disorder, then the next test that we will want to perform is the Haemoglobinopathy screen, or the HPLC, which, if it shows a raised hemoglobin A2 and raised hemoglobin F, will be pointing towards a beta thalassemia disorder. Blood film morphology, transfusion history, these are all things that we need to assess and take into account of. Obviously, the geography of the patient. So it's really important when we see patients with thalassemia that we don't forget to take into account their ethnicity and whether they're from a region where we expect to find a thalassemic mutation. Whether they're antenatal or not. Now, this is very important because many patients who, if they're not antenatal, we may not investigate them any further. We may not do any genetic testing. However, if it's a lady who's pregnant or considering trying for a pregnancy, then it may be much more important to ascertain what type of thalassemic disorder the lady has if there's a potential of an interaction with the partner. And then other aspects of antenatal testing include partner testing. So I'm now going to move on to the iron chelation part of the talk. I don't know if you want to have a break for any questions, or should we just do it at the end? Should we carry on? Yeah. So I'll try and keep this, again, relatively brief. So with treatment for thalassemia, the problem arises that patients who are well transfused will tend to develop iron overload at a very early stage. And normally, iron overload manifests very, very soon after the patient starts on a regular transfusion program. We would normally aim to start iron chelation therapy when the ferritin is above 1,000 micrograms per liter, which approximates to when the patient has received 10 to 12 transfusions. In terms of how we monitor patients for iron overload, so there are various parameters that we can use, including blood tests to look at the serum ferritin. We normally start to investigate patients and do radiological investigations when the ferritin is above 1,000. And we know that when the ferritin is above 2,500, then this is associated with a significantly increased risk of complications. However, there are some drawbacks and there are some limitations of using the ferritin alone. The ferritin is an acute phase protein which can be raised in other circumstances, for instance, in the context of inflammation or infection. The current guidelines recommend in transfused patients that we monitor ferritin every 3 months, and in non-transfused patients at least on an annual basis. The gold standard for assessing for tissue iron overload used to be by performing a liver biopsy to directly estimate the amount of iron in the liver by dry weight. However, with the improvement in radiological technology, MRI technology in particular, we now rely on T2 star cardiac MRI and R2 MRI or FeriScan to look at the liver iron. And in particular, the FeriScan is a non-invasive method of looking at liver iron concentration. And as opposed to T2 star hepatic MRI, the R2 MRI is designed in such a way that it is not affected by inflammation or cirrhosis. Less than 3 milligrams approximately per gram dry weight is normal iron concentration. Above 15 milligrams per gram is associated with significant long-term hepatic complications and with cardiac disease. Here we can see a picture of the R2 MRI. Actually, sorry, this is a T2 star MRI, not an R2 MRI. And this just shows the discrepancy between hepatic and cardiac iron deposition. So the darker areas here show areas of iron deposition. On the left side, we can see an individual with significant hepatic iron overload, but sparing of the heart. And on the right, we can see the converse, where there is significant cardiac iron, but not any significant hepatic iron. And this is typically seen in patients, for instance, with sickle cell disease, where they get hepatic iron. And in thalassemia, there is more of a tendency for iron to deposit in the heart. And the reason for this difference is not particularly well understood. So this just shows the difference that the advent of iron chelation has made to the survival of patients with thalassemia. So the first iron chelator was developed in the 1960s, which is desferrioxamine. And we can see here the various decades prior and after development of the iron chelator. We can see the survival has improved very dramatically after the advent of iron chelation therapy. And this is just showing compliance with desferrioxamine infusions, that patients who had fewer infusions per year had a much worse overall survival compared to patients who were more compliant and having larger numbers of infusions per year. And you may ask yourself, I'm sure most of you know, why compliance may be an issue with these patients in terms of iron chelation therapy. But if we look at this slide, there are numerous factors that influence patients not being very compliant with their iron chelation, particularly with the desferrioxamine subcutaneous infusion. And you can imagine, especially in young patients who are attending school or adolescents or teenagers, many of these aspects emotional well-being, sleep disturbance, pain at the needle site, affecting their social life, not wanting their friends or colleagues or peers to know that they have a disorder that requires regular treatment, effects of the self-esteem. All of these issues contribute to why patients may find compliance with these therapies particularly difficult. So just to whiz through the different iron chelators, we have 3 iron chelating medications which are available to us. Deferrosirox is actually the last one to have been marketed, which is an oral iron chelator, which is now the most commonly used. Desferrioxamine, which was the first iron chelator to be developed, which I mentioned in the previous slides, which is given as a subcutaneous infusion, usually several times a week. And deferiprone, which is another oral iron chelator, which is administered orally 3 times a day, which tends to be more effective in reducing myocardial iron compared to the other chelators. It does have a significant side effect of agranulocytosis, which is a severe, rapid, and unpredictable drop in the patient's white blood cell count, putting them at risk of severe infection complications, and therefore patients who are on this medication need to have regular monitoring of their blood tests for the whole duration of treatment. And then some patients require combination therapy with more than one iron chelator. And this slide just shows the fact that deferiprone is superior to desferrioxamine in reversing cardiac iron. So here we can see the improvement in the T2 star value, which is greater with deferiprone compared to desferrioxamine. And here we can see also the improvement in left ventricular ejection fraction, again, which is greater with deferiprone compared to desferrioxamine. In the last couple of minutes, I'm just going to just make you aware of some of the newer developments in the treatment of thalassemias. So there have been some clinical trials of newer agents in thalassemic disorders, and this is one example of a clinical trial which we were recruiting patients to in our center a few years ago, which is a drug called mitapivat, which is a PK activator in non-transfusion dependent thalassemia. And a related drug to mitapivat in the same family is this drug here called etavopivat, which is now we are hoping to open some studies to recruit patients to these drugs, to these trials using this drug etavopivat in patients with thalassemia. So I'm not going to really have time to go into the details of how these drugs work, but just to make you aware that there are some treatments now which are being looked at to improve the hemoglobin level and various other clinical parameters in patients with thalassemic disorders. And this is just another example of a trial which we are awaiting to open in our center and hopefully recruit patients to with non-transfusion dependent thalassemia. And this works in a different way to the other trials which I've mentioned, improving the iron overload in patients with thalassemia. And then I'm sure you're all aware of gene therapy. Just to mention that there are different approaches to gene therapy, including lentiviral approaches, but the approach which has been most successful recently and has now been approved for use in patients with thalassemia is the gene editing approach using CRISPR-Cas9 technology. And what this does is it knocks down a gene called BCL11A, and that allows, this is a gene which becomes activated a few months after birth, and it represses gamma globin gene production, and knocking down this gene allows the gamma globin gene production to restart and mimic the situation which would be seen in babies during fetal development and after birth. And this is the nice approval of the gene editing therapy in patients with transfusion-dependent thalassemia. So it's currently approved on a managed access scheme, you can see here. And this is approved for patients who are suitable or eligible for a hematopoietic stem cell transplantation, but do not have a matched or suitable stem cell donor, HLA-matched stem cell donor. So you're going to hear a talk later today from the team at Vertex who market this technology, this treatment for thalassemia, and you'll hear some more from Dr. Okoli on its indications in sickle cell disease. But I thought it's important to mention, as it has been approved by NICE for the use in patients with non-transfusion dependent thalassemia. So I know that was a really quick run through a huge amount of information, but if you have any questions and if there's time allows, I'd be happy to take one or two.
Yeah.